Dr. Harrison. How are you?
Good, Dawn. How are you?
I'm fine. It's such a pleasure to be with you this morning. You have such an impressive resume. I know I could stay here for a long time, but I want to be cognitively aware of your time. So I'm just going to jump right in. Please introduce yourself and tell us a little bit about yourself.
Sure. Let's see. Dr. Nzinga Harrison. I'm a physician, double board certified in psychiatry and addiction medicine, co-founder and chief medical officer of Eleanor Health, which is a multi-state substance use disorder and behavioral health provider. So we function like a behavioral health medical home, offering longitudinal substance use disorder care in North Carolina, New Jersey, Ohio, Louisiana, Massachusetts, and the state of Washington, with value-based reimbursement. So that's really important, being held accountable for our outcomes so that we're incentivizing quality of care rather than quantity of care. I am also host of a podcast, In Recovery, produced by Limonada Media, where we talk about all things addiction, really with an approach of compassion, stigma reduction, and evidence-based. So that's one of my favorite things to do. And then also co-founder of Physicians for Criminal Justice Reform, which is an organization of physicians and other allies of all professions that advocate at the intersection of health and criminal justice. And executive advisory board member for the newly formed SAMHSA Black and African-American Behavioral Health Center of Excellence, which is what gives me the opportunity to be on here with you today for this interview. And more important than any of that, wife and mom. So, and daughter and sister and friend and cousin and all of that. But I have an amazing husband and two teenage boys, 15 and 14.
Oh, that's quite impressive in the least. And you stay very, very busy. But all of the work that you do really assist us in moving things forward when we're looking at behavioral health disparities for African American. And I'm so excited because on behalf of myself, who is Dr. Don Tyus and Morehouse School of Medicine, with Dr. Valerie Montgomery Rice as our president, we're excited to have you here to share with us as we do this video series for the newly founded African American Behavioral Health Disparities Center of Excellence. I'm just going to jump right into these questions. You are a highly impressive scholar, a highly skilled clinician and researcher, a highly effective leader, but that's not even the best of it. You're also a visionary, a groundbreaker, and a tireless activist. What made you who you are?
That was such a beautifully worded question, Dawn. I think what made me who I am is the privilege, and I use that word intentionally, the privilege of being raised by parents who poured into me. So I don't underappreciate how important it is that I was raised by two activist parents. So growing up, I grew up in Indianapolis, Indiana in the 80s, mid 70s to 80s, if I have to, show my whole age. My father was an electrical engineer by night. By day, he was commander of the local Black Panther militia.
Okay, that's powerful.
My mother started as a public school teacher and then stayed in the public school system her entire career, ultimately becoming chief of human resources. And so I have pictures of picketing on behalf of teachers with my mom. I have pictures of picketing at Black Power events with my dad. And it really was baked into all of us that one, you are infinitely capable as a human being. And two, it is your responsibility to raise your voice against inequity and injustice. And I think I knew young that I would be a doctor. I was enamored by the human body and science and physiology and anatomy. I didn't necessarily know that I would be a physician activist, but I think there's no way I couldn't have been because of my parents.
So it really was ingrained in you from birth, basically. And I wanted to know so much. I really wanted to get to know Dr. Harrison, Dr. Nzinga Harrison. So one of the things that I found that the original Nzinga was a freedom fighter during her reign in the 1600s. As the Queen of Ngada and Matamba, repelling the Portuguese Empire and making her land a sanctuary for runaway slaves, which means you definitely stand up to the name of Nzinga. What are some of the costs and benefits of being all of those people, a mom, a wife, an activist, a physician, all at one time?
It's funny, you want your good news or your bad news first, or some people say you want your desserts or your vegetables first. So we'll eat the vegetables first, then we'll go with dessert, starting with cost. I think the cost is having to be extremely aware of my cup getting empty.
Mm-hmm, mm-hmm.
And I'm actually, despite being an accomplished clinician and psychiatrist, like many, I can see when other people's cups are empty way better than I can see when my own cup is empty.
Mm-hmm.
And so I think kind of the cost of being all those things is this natural ebb and flow of getting empty and having to figure out how to refill my cup. The other thing I will say is I take it as a huge responsibility, the number of people who look up to me or look to me for guidance in each of those different kind of life roles that I have. And so that comes with a sense of stress, right? Like, I don't want to let people down. I want to be making the best choices I can make. I want to be not missing opportunities to raise my voice in advocacy. So those are the vegetables, even though I love vegetables, so no shade on vegetables. For the dessert, which are the benefits, are just like, I thrive on seeing sustainable change.
Mm-hmm.
I thrive on seeing people meet their potential.
Mm-hmm.
I thrive on seeing systems address their inadequacies and get better. And so when you're in so many different roles, from wife to mom to treasurer of the PTSA at the high school, which I am, to secretary of the Principal's Advisory Council, to podcast host, to executive advisory board member, to co-founder, to chief medical officer. And all of those roles are just so many opportunities to be touched by so many people, collectively making a difference on so many systems, that it is, I mean, the opportunity is overwhelming. So
that's so amazing. I really appreciate you sharing that with me, because even though this is our first interview and this is Women's Month, so power out to the women, but you're doing an amazing job in all of your roles. And I think when you talk about sustainable change, it takes a collective approach to do that. And you definitely have that down pat. There have been some really important discussions in the field about the need to move from a fee for service model to a value-based model, fee for performance model. But at Eleanor Health, you haven't just been talking about it, you've actually been doing that. Please tell us a little bit about how you've moved from a value-based model and how is this going?
Walking the walk. So Eleanor Health is so amazing. I've routinely said that it's the most important thing I've done with my career to date. And I believe that the impact that we're going to have more widely on the substance use disorder treatment industry makes that the case. Just to do a little quick education, fee for service is what people typically think about in healthcare. You go to the doctor, they drop a bill, you get a claim, the insurance pays it. If you're lucky enough to have insurance, you pay your copay, your deductible. If you're not lucky enough to have insurance, you get the whole bill in the mail and then you go bankrupt. So what shade on the current healthcare system. What that drives is quantity of care, right? To keep your business open, if you're a healthcare system, you have to drive quantity of care, because the more services you provide, the more money you make. And there's no accountability for the outcomes that those services produce. What we're saying at Eleanor Health is, first of all, fee for service reimbursement drives inequity. Because where do you have to put your business? Where there are enough people who can pay for it. That disenfranchises people in poor communities. Right. Where can you really exploit fee for service? In marginalized communities that don't have people to advocate for them. So that's where you see scams popping up and stealing people's money. It creates two different health systems for people who can pay out of pocket and people who can't. It drives racial inequity. It drives social inequity. And so because it doesn't matter if the population is getting better, as long as you provide the service, you get paid. At Eleanor, what we believe is that we should be accountable to the people who are entrusting us with their health. And so value-based reimbursement, or even we're moving to the next phase, which is population-based healthcare, is like, let us identify a population of people who could benefit from our services. We will go become part of the community, engage those people in trusting, compassionate relationships, deliver evidence-based care, and you pay us for that. And then if people's substance use disorder don't get better, if their depression don't get better, if their anxiety doesn't get better, if their life doesn't get better, housing more stable, relationships richer, meaning and life purpose found, connectedness increase, if that don't happen, we'll pay the money back.
Oh, that's powerful. That's powerful.
Accountability for people getting better. So then you align the incentive of human beings' lives getting better with the financial incentive. Unlike in fee for service, where you just have financial incentive and it doesn't matter if people get better.
That's a powerful model. And I really think that that is what's needed to help us eliminate health disparities in African American communities. You spoke about that so eloquently. And I know that you're the founder of a wonderful activist organization called Physicians for Criminal Justice Reform. How would you describe the impact of disparities in the justice system on the physical and behavioral health of African American communities?
So co-founder of Physicians for Criminal Justice Reform, our founder is Dr. Eja Endom, who's a neurosurgeon. It is inextricable, the impact of these other systems on health. So when you look at the criminal justice system, I could have easily have co-founded Physicians for Education Reform, or Physicians for Housing Reform, or Physicians for Banking Reform, or Physicians, like every single one of Physicians for Healthcare Reform. How about that? Right? Because every single one of these systems is affecting our health, because our lives are our health. So when you look at, even specifically for substance use disorder and behavioral health, before the 1800s, there were no illegal drugs. There were drugs, but none of them were illegal. And when laws to make drugs illegal were developed, they were developed because of racism. So the first illegal drug laws were against opium, targeting Chinese immigrants. The next laws were against cocaine, targeting Black men in the South. The next laws were against marijuana, targeting Mexican migrants and immigrants. And so the war on drugs, which has really been a war on people, is one of the number one criminalizing factors that has led to the mass incarceration we see today. And when you look at that mass incarceration, disproportionately, who's represented? Black and brown, because the laws were made to do that. And so when you look at criminal justice or criminal injustice as it comes through the disparities that you can see for who's incarcerated, you think about ACEs, adverse childhood experiences. These effects are generational. So not only do we have the school to prison pipeline, where Black kids, boys especially, specifically from 7th grade, have a straight line to jail and prison, because we have resource officers, police officers in the school arresting our kids. You have fathers and mothers going to prison. That is an ACE score. You just gave that child an ACE score of 1, which predicts their chronic physical and mental health difficulties later in life. Generational impacts, the trauma that happens while people are incarcerated, generational and lifelong impacts on physical health and mental health. When people come out from being incarcerated, the ostracism they face in society, the laws that are designed to make them never be able to recover to an independent, meaningful, purposeful life, lead to mental and physical health conditions, and then specifically for our youth who are being locked in adult prisons and preyed on.
Yep.
So represent an overwhelmingly disproportionate number of detained people who are raped in prison. Those are our children. Those traumas come with them outside of that criminal justice system and linger with them for their lives, for their communities' lives, for the next generation's lives. So it's infinite the impact that the criminal justice system has on health and health disparities.
And I definitely agree with you on that. And that's one of the reasons why I feel that the African American, this center of excellence is so important, and that why we should have this video series first is because before we really just jump in the trenches, I don't think people really understand the profound impact or the effect that a lot of the history has had on to getting us to where we are today with these disparities. So you're providing us with some amazing education, which my hope is for the center, as well as all of our collaborative partners, that we are able to utilize this information, have thought groups, have focus groups to really have a serious impact, as you stated earlier, for sustainable change. And I think that that's very important. We can't just jump in the trenches and do the work without really looking at the history of how all of this started and looking at the different systems. And one of the things that you left me with, we had our conversation the other day, is as I thought about it and I've been thinking about it, it's really looking at holistic care. When you talked about the financial system, the housing department, the criminal justice system, just helping the entire overhaul in the entire system so that we can help eliminate some of these barriers for African American people. So I thank you so much. But there is a lot of myths and misconceptions about African Americans in the behavioral health field. And sometimes these can affect practitioners, their perception and their choices, like diagnostic interpretations and their choice of evidence-based interventions. What are some of the most common myths and misconceptions that you can speak about today?
I want to use this question as an opportunity to talk about implicit bias.
Okay.
And the reason I want to start there is because, first of all, the definition of implicit bias is that you have thoughts about a certain group of people that you don't even necessarily know you have, unconscious, right? So people think about racism, and racism is like explicit, like, I don't like Black people. It's dangerous. But implicit bias, which is where you have some bias against, and I'll talk specifically about Black people here, and you don't know it, is as, if not more dangerous. And so if you look at the images that we see in the media, and there's been a remarkable change over the last 6 to 8 years. Prior to 6 to 8 years ago, really overwhelmingly, when you saw Black people on TV and in the movies, it was the news, and we were criminals, and we were robbing people, and we were murdering people, and we were poor, and we were addicted to crack. And so even if you didn't want intentionally to have that as your image of Black people, you're being inundated with that. And this is all people, this is people of all races and ethnicities. So Black people getting inundated with this also. In the last 6 or 8 years, we start to see Black families and Black professionals and Black artists and but before that, it was athletes and criminals. And so that implicit bias infuses the mental health care system and providers in mental health care as well, right? The other image I'll say is slaves. So the only history you hear about Black people is slaves. And then you see criminals and poor people, and then the criminal and poor people that made it out are athletes. That was like all the images of that was the totality of Black people.
That's correct.
Images in the media, right? So luckily now we're getting a more diverse image, but all of those have been programmed and all of those result in implicit bias. And so when a Black person walks into a mental health office in front of a mental health practitioner, we know that the literature shows us a Black person who is depressed is more likely to be perceived as angry.
That's correct.
A Black person who is angry is more likely to be diagnosed with a psychotic disorder than with a mood disorder. A Black person who is anxious is more likely to be perceived as aggressive.
Mm-hmm.
A Black person who has can advocate for themselves
Mm-hmm.
is more likely to be perceived as drug seeking.
Mm-hmm.
All of this is not necessarily explicit bias against Black people. It's implicit
Mm-hmm.
because criminals are aggressive.
Right.
Criminals are angry.
Powerful.
Criminals are drug seeking,
Mm-hmm.
right? And so
Right.
those implicit narratives that we've been programmed with about Black people, if we don't take the responsibility to raise our awareness of our own bias,
Mm-hmm.
then we act out on them. And the way you see that acting out is with disproportionate psychotic diagnosis in Black people, disproportionately Black people being referred to jail instead of treatment for mental health conditions,
Mm-hmm.
disproportionately Black people having discriminatory experiences with the physical and mental health care system, and as a result, not trusting that system to access it when care is needed. And as a result, having premature death, higher rates of psychological distress, higher barriers to accessing care, higher attrition and dropout rates from care, and worse health outcomes.
Mm-hmm.
So you asked a little bit of a different question, but I felt like it was important to take that walk through implicit bias all
That's
the way
great.
to the outcomes we get, because
Mm-hmm.
it's when you think about myths and misperceptions, it'll be like, oh, Black people don't feel pain as much as white people. Actually, medical schools were teaching this when I was in medical school,
Right.
and I'm not that old,
Right.
right? I'm like
Right.
young old. I'm not like
Uh-huh.
old. So that wasn't that long ago. And a study just came out a couple of years ago that said more than half of medical students and residents still believe that Black people have higher pain thresholds.
Mm-hmm.
So
Wow.
that is like a discrete myth, but as importantly as that explicit myth are those implicit myths that we have to navigate as well.
I thank you for definitely bringing that out because it's just stigma was all over that for me.
All
And I
of
think that we work so hard to try to break down the stigma, but I also think until people deal with those implicit biases and take a look inward, we'll always be where we are. And that has a lot to do because our practitioners are our community providers. And if they don't start to address it, not just but from the top all the way down to the janitor, to the receptionist, everyone needs to take a look inward so that's the only way we're going to start removing some of the stigma that we have over Black and brown people. And that's very key. And one of the things that I have really started trying to push, one of my hashtags is Black Women Do Heal. And the reason being is because I think that is powerful just because I may use hand gestures or maybe because I'm in the boardroom and I may say, no, I disagree. And my facial expressions is still, I'm not an angry Black woman. I'm speaking and I'm stating, you please take that myth off me. This is a form of expression. So there are so many stigma that lies in so many different areas of our lives as Black and brown people. And I think that it's a charge of the Center of Excellence to make sure that we address and we teach people how to look inward, how to remove the stigma from themselves so that they can provide more quality care. So that's important. So I do thank you for taking the question and putting a little spin on it for you. What about some of the common beliefs about specific interventions for us? Like the ideas that African Americans don't do well on medicines like buprenorphine. What would you say to providers about that? And I think you spoke a little bit about that when you were talking about the pain, but let's talk a little bit about that.
Yeah, so there is this prevailing myth that Black people don't do as well on medications. And I'll tell you where, and buprenorphine specifically, and that is a deadly myth when it comes to buprenorphine because buprenorphine saves lives from opioid overdoses. The face of the opioid crisis has been a white suburban face. And that is very dangerous for communities of color because it sends the message that it's not affecting us. When in fact, from 2014 to 2017, the largest absolute and relative increase in opioid overdose deaths was among Black communities. And so this is killing us like it is killing white communities and other communities of color as well. And so this myth that buprenorphine doesn't work as well is a deadly myth. It is contributing to the premature death that we see for the Black population compared to other communities. I think part of the reason is because Black as a population are disproportionately affected by social drivers of health that are unstable. And our healthcare system is not equipped or has not taken the responsibility to manage social drivers of health as part of healthcare. And so it's not that medications don't work, it's that when you're not addressing all of those other competing factors, those are undermining the ability of that medication to work. And so I was just looking at Eleanor Health's data by race a couple of weeks ago. And our Black community members, so we're building community at Eleanor, so we don't call our people patients, we call them community members. So our Black community members start treatment faster. So from the time they call to ask for help, their first appointment is faster. They have a higher rate of engagement. So the number of appointments they have in the first month is higher. Depression scores improve faster. Anxiety scores improve faster. Recovery capital, which measures social drivers of health, because we make a big investment in social drivers of health at Eleanor Health, improve faster. And yet, Black people are still dropping out of our community at higher rates than other races. I don't know why. But if I didn't look at the data, I wouldn't know that we have an opportunity there to try to figure out why and to try to talk to our community and figure out why. So when you have this myth, so like a Black person that seeks treatment for opioid use disorder is up to 35 times less likely to get a prescription for buprenorphine. It's implicit bias because I think you're drug seeking. It's implicit, it's access bias because the access to prescribers that can prescribe buprenorphine is not concentrated in communities of color.
Right.
Right. It's the cumulative deprioritization that Black people face when they go into urgent and emergent care settings, just as a part of like overall implicit racial bias. And so when you develop the myth that medications don't work, then what do you not do?
Correct.
Prescribe medications, even though that's the standard of care, even though that saves lives, even though that improves outcomes. What we need to do then is instead be looking at what are the social drivers of health? What are the barriers? How do we take the responsibility to remove those barriers so that Black communities can be getting the same standard of care as other communities, despite these myths and biases that persist?
I totally agree, because that's powerful. There were a few things that stuck out. One of the is that I see that Eleanor Health is really trying to eliminate the stigma as much as possible, even with changing how you perceive your clients and indicating community members. And I think that that's really, really key. And I think that that goes along with the engagement piece and making your community members feel welcome, having a part in their actual care is really a key to sustainable change, and making sure that they have that level of access, meeting them where they are. And that's powerful. And as I listen to you speak, a lot of this goes just back to raising the awareness, but also taking the opportunity to educate yourselves. You know, a lot of the practitioners, and not just, taking it for face value, but putting in that extra work to get to know the history, the culture that you're actually dealing with, and being a little bit more, I think, I'll put it in the phrase of culturally humility, making sure that you're really providing that level of care that they feel as though you're interested in their well-being. And I think that that's key. That's important. So, this is so good. This is very, very, very good. I've heard you speak so eloquently about the need for accountability in the behavioral health field and the need for instruments that will provide access to the cultural relevantness and appropriateness of their services. Please tell me a little bit about your vision for this.
My vision for accountability in healthcare. So I always like to talk about the quadruple aim, right? The quadruple aim says we can improve the health of populations. We can give a wonderful experience to people we're serving. We can give a wonderful experience to the people who are doing the serving, so the care team members, and we can do all of that for a reduced cost of care. And so when I think about outcomes, and this is like our culture at Eleanor Health also, yes, having been affected by substance misuse is what we say turns the key to the front door of the Eleanor home. But when you walk in our home, you are walking in as a whole person. And so that means I can't think that only a negative urine drug screen tells me what I need to know about you. So when we're looking at people who are presenting for substance use disorder care, we know that 80% are going to have a co-occurring, another co-occurring mental health condition, because substance use disorders are mental health conditions. And if anybody want to fight me on that, we can go.
I'm right there with you as a clinician.
Okay, we don't have to fight. Thank you.
We don't have to fight. I'm with you.
These are not my fight clothes.
Right, that's right.
If you're not screening for depression and anxiety with psychometrically validated scales, and you're not screening for trauma and adverse childhood experiences, then you're not providing effective care. You're not going to get the best outcomes. If you're not screening for comorbid physical conditions, because we know that all the social drivers of health that are driving substance use disorders and other mental health conditions are also driving physical health conditions, then you're not providing the best standard of care and you're not going to get the best outcomes. If you're not quantifying the needs of the people you serve as it relates to social drivers of health with a validated scale, and then addressing those as part of the service that you're providing, you're not providing the best standard of care and you're not going to get the best outcomes. If you are not getting to know the cultural, racial, ethnic experience that the people you're taking care of have had before they got to you and how that has affected their health, you're not giving the best standard of care and you're not going to get the outcomes. People are going to drop out, right? And so when I look at what outcomes I want to see being measured routinely, yes, substance use disorder, absolutely. Urine drug screens is the objective measure we have of that, of course. Depression, anxiety, trauma, physical health conditions. If I'm not worried about your blood sugar, I'm not taking care of the whole you. Social drivers of health to include housing stability, safety, financial security, but extremely importantly, social connectedness, life meaning, and purpose, because that's what drives health. Relationships, life meaning, and purpose drive all the rest of everything. And then finally, the impact of your identity. So I'll broaden this beyond just Black for in this answer to say, when I'm in a room full of men, I feel my womanness acutely. When I'm in a room full of white people, I feel my Blackness acutely. When I'm in a room full of lawyers, I feel my doctorness, or I guess I really feel my not a lawyerness acutely, right? Because that's really what you're feeling. You're feeling you're not a lawyerness, you're not whiteness, you're not manness, right? When we're talking about our queer and trans community members, they feel they're not straightness when they're in a room full of people who appear straight. Those cause psychological and physiological burden that we experience every single day. And so if we're not addressing that, and if we're not addressing the trauma that is racism, although every single behavioral health provider will tell you evaluating trauma is standard of care. So if evaluating trauma is standard of care and racism is a trauma, I mean, this is high school math. This is middle school math.
Middle
A
school
equals
math.
B equals C.
That's right.
Then evaluating racism
Yes.
should be standard of care if we
Mhm.
want to get the outcome, which is reducing the health disparities we see for
Mhm.
Black populations.
Eleanor Healthcare, just listening to you, they have an amazing model. That's just an amazing model. And I think that it's a model that really people needs to be out there so people can really do like an organizational checklist to see what components of their organization they're missing, because that is the one of the only ways that you're going to be able to really look at what those disparities are. And you can't just do top surface. It does require some work, and it does require spending some time with your actual client just to make sure that you're truly understanding them. Because if you don't take time with them, then you're not preparing or providing the level of care that's needed so that, again, they can stay in treatment. I mean, that you can really get the outcome that you're seeking. And I know we've been talking a lot, and I just have two more questions. One is just kind of like one question that I'm going to save for last. It's really just about you and your strength. But the question that I think that would really drive this home is this has been a year when many non-African Americans have been opening up to learning about the effects of economic, health, and justice inequities of African Americans. What kind of opportunities does this open up for those of us who want to educate the public and the field about behavioral health?
Massive opportunity. So, in fact, how many decades has advocacy for the creation of an African American Behavioral Health Center of Excellence been going on?
Decades. Mm-hmm.
The fact that the African American Behavioral Health Disparities Center of Excellence, and help me get the name right, Dawn, because I think I call it a little bit different every single time.
It's the African American Behavioral Health Center of Excellence.
I'm gonna get it together. The
Okay, you
African
good?
American Behavioral Health Center of Excellence. The fact that SAMHSA has formed this now
Mm-hmm.
is a direct reflection of the magnitude of the opportunity that we're
Mm-hmm.
standing in the middle of. And I think the biggest opportunity is that emotionally, people are opening themselves to the risk of doing this work as individuals, as companies, as systems. And so that's what I hope for our COE as well, is for us to create a sense of safety. I think the second part is that collectively there's this increased sense of responsibility to do this work. So this work has been ongoing by a small group of very committed people whose voices have not been magnified by the majority for decades. And now the majority is taking the responsibility, developing the desire, feeling a sense of safety to magnify the voices of decades of foundation that has been laid. And so I think that's a massive opportunity. And then I think just very tactically, money is coming.
Right. I agree.
As a result of this awareness, as a result of this desire, as a result of this sense of responsibility, money is coming where there has been no money before. And so when you put awareness plus desire plus a sense of responsibility plus resources, that's when it's go time.
So, Dr. Harrison, as we move forward, what are some of those things that we can do as individuals to make sure that it can help pave the way and assisting providers in actually in their day-to-day work to help eliminate these behavioral health disparities?
I really think you emphasized it earlier, which is looking within. So this is the first thing, even as I'm advising or consulting to systems or organizations, the first thing I do is individual work on implicit bias. And so I'm going to give two very tactical things that any individual can do right now. Project Implicit by Harvard, just Google it, Project Implicit. You can take an implicit association test, IAT, and it will tell you what biases you have for, against, or neutral. as it relates to all sorts of groups, choose the one, because this is the African-American Behavioral Health Center of Excellence. Did I get it right that time?
You got it right. You got it right.
Choose the one for race. You may be surprised. And this is not, I'm not only talking to my non-Black people, I'm talking to all my people.
Mm-hmm. Mm-hmm.
You may be surprised by your biases. And the very first thing you can do is raise your awareness of your bias. Like, that's the first step for a reason. Right. Recognizing we have a problem.
That's right.
Because once you recognize it, then you're empowered to figure out what to do about it. If you don't recognize it, then you're just acting out on it, even if that's not your intention. So that's number one. Take the implicit test, IAT, Project Implicit. Number two is take the risk to have this conversation.
That's powerful.
Take the risk to have this conversation with whomever in your life feels safest, right? Grab the lowest, safest environment, because the more you have this conversation in a safe environment, the more you can take the risk to have the conversation in environments that feel less safe. There is someone in your life who is willing to have this conversation with you. Take the risk to have the conversation.
I think, like, and I state as the principal investigator of the Center of Excellence, I'm telling my staff, just constantly telling my staff, is that you may not get but one shot. So we have to make sure that we're strategic, but more than anything, that we're impactful. And we utilize and do what it is that not only for SAMHSA, because we're so grateful that they're providing this opportunity, but also we have to understand that our charge is to the people, our target audience. And the target audience is helping our providers, our health system, really look at and take a deep dive. And we may not always get it right, and we may not do everything that needs to be done, but we need to start looking within. We need to start collectively coming together and respecting those vulnerabilities, setting up, as you stated, those safe spaces that we can really take a deep dive at this work. That's the only way we're going to be able to start even eliminating these disparities for Black and Brown communities. You've given us so much information, and you just very knowledgeable. As I stated, you're a scholar, but also, your strength is just shines through. So my last question is just, a lot of us are out here, we're really plowing, African Americans, Caucasians, Hispanics, all of us are really working because they're good people in a lot of all of these cultures. But how do you remain so open, so authentic, and so heart-driven and resilient?
I'm gonna give this to my parents again. My parents and my family life growing up, it was okay to have emotions. My mom is a crybaby. My dad, commander of the Black Panther militia, is the biggest crybaby. Like, that man will cry at the drop of a hat. I'm a crybaby. Passion and emotion were not scary in my family. It was like part of being who you are. And so I think part of being able to remain open and vulnerable is that I don't have to put a cap on my emotions. I don't have to hide my emotions. I don't have to hide who I am. Like, I can let people see me. Probably if you Google 5 interviews with Nzinga, 3 of them Nzinga drops a tear, right? Like, it is okay to be passionate. It is okay to cry. It's okay to feel devastation. It's okay to really mess up bad and try to get it right the next time. These are like the I guess, values that were instilled in me growing up. And I really think one of the ways we handicap ourselves and our upcoming generations is this idea that emotions are dangerous or you have to always have it together. So, like, I don't always have it together. Okay, I put it together for the interview today. No,
we both did.
I checked on and I was like, how together do I have to get for this interview? But I don't always have it together. Sometimes I wake up on a Saturday morning and I lay in the bed and I cry because it's overwhelming.
I think that's very powerful. And I think that's an amazing way to end this interview, because as you were stating, I think that it's very, very important that as we're doing this work, that we be okay with being open, that we be okay with showing our emotions, and that more than anything, we be okay with when we just can't do it, we can't do it, but more staying in the fight is the key. So I thank you for being on our advisory board. I thank you for taking the time today to really just share a lot of insight, because this is really what we need in order for us to be able to be strategic and impactful in our work on eliminating behavioral health disparities for African Americans. Thank you so kindly, Dr. Harrison. I really, really, really appreciate you. You know that I do.
Thank you, Dr. Tyus.
You're welcome. Thank you.